before using a transfer, amazing transfer, but difficult to do, remarkably described by Bassam El Assam, I think there is a place for conservative treatment for treating serratus anterior palsy. My disclosure. I think everybody here perfectly knows the different functions of serratus anterior. This muscle has to stabilize scapula on the chest, to push the scapula forward, to fix and push the scapula on the chest, and to move the arm up to 90 degrees of elevation. What is the surgical anatomy of the long thoracic nerve? From its origins, from C5 to C7 roots, it has a proximal portion through the scalenus medius and around the second rib. But the thoracic portion is more interesting. It runs along the third posterior and mid fibers of the serratus anterior, and it passes under the anterior branch of the thoracodorsal artery. Jackie Lolland, doing serratus anterior flaps, find a compression, a possible point of compression between the free and fixed portion of the long thoracic nerve. When it passes at the crossing between the long thoracic nerve and the thoracodorsal artery, and under the fascia of the distal portion of the muscle. You see here on this view the long thoracic nerve and the thoracodorsal artery crossing it. The main aspect of the serratus anterior palsy has a mechanical origin. It is a strictly isolated palsy. It's a mechanical lesion of the long thoracic nerve by trauma or microtrauma, by compression or stretching, and besides the two classical anatomical sites of compression, there is a true compression site on the lateral part of the chest. And we have to know that the spontaneous recovery is uncertain. What are the clinics? The most classical one is the scapula alata, and sometimes it's complete, 50% of our cases, often partial. Second symptom, the pain in 2/3 of cases, neurologic pain on the lateral part of the thorax, or muscular pain, or subacromial by secondary to the subacromial winging, the subscapular winging, pardon me. What are the clinical signs? Limited abduction or elevation, the weakness for elevation against resistance, against wall. We have to check if it's isolated to differentiate from Parsonage and Turner, and if there is a sign, a Tinel sign on the lateral thoracic rib. But we have to take care on other causes of scapular winging. Of course, the Parsonage and Turner syndrome, pardon me. The context is totally different because in the Parsonage and Turner, the palsy is not isolated, and we have two different steps. First of all, the pain. Second, the palsy. Bassam El Assam describes the differences between serratus anterior palsy and trapezius, but the trap is scapulothoracic dyskinesia, I mean functional scapulothoracic dyskinesia. But it's possible to detect it by close kinetic chain exam. Could you launch the video, please? This guy has a scapular winging with a weakness of elevating arm, but if you do the same thing in the closed kinetic chain, it's able to stabilize his scapula. It's not a serratus anterior palsy. The series, we have 56 non-iatrogenic cases of palsy. The age is around 33 years. The causes are microtrauma in 33 cases. The mean duration of symptom was around 2 years. And before the operation, we had 26 complete paralysis and 30 partial. The pain was neurogenic in 27 cases. And every time, the diagnosis had been confirmed by electromyographic studies. What were the results of the surgical treatment? It's not difficult to do this release of the long thoracic nerve by a short incision just in front of the latissimus dorsi, as you see here, centered on the fifth rib, and after dissecting, you could find some different things. Vascular abnormality in more than 50% of cases, fibrosis in 12, and both in the rest. There were no complications related to this surgery. And on every case, we observed a click alleviation on pain. All the patients had a profit, at least partial, after this procedure. There is a huge difference between 18 months of duration of symptom. Before, every patient has a good result. After, it's maybe difficult to predict. Some example, this lady, palsy in 15 months after simple stretching. We found a vascular branch crossing the nerve. As you see here, the nerve is there, the artery crossing the nerve, and after 8 months after the release. There is bad prognosis factor, duration of the palsy, more than 18 months, it's a bad prognosis factor. The muscular pain, which is secondary to the scapulothoracic dysfunction. And we mean that surgery is indicated when spontaneous recovery doesn't occur with the first 2 to 3 months, first 3 to 6 months. Conclusion. The isolated paralysis of the serratus anterior is due to the tension on the long thoracic nerve or direct compression on its thoracic portion. The release of the thoracic portion of the nerve is a simple, safe, and efficient procedure. But persisting problems are mainly observed in long-standing palsies with muscular dysfunction. Thank you so much.